Yeah.
So welcome everybody to our next webinar. And this webinar will be delivered by Professor Nelson Dusetti and is entitled From Tumor Models to Treatment Decisions, Building a Precision Oncology Framework for Pancreatic Cancer. It is really my pleasure to introduce Professor Dusetti from the Cancer Research Center of Marseille, where he leads the translational and therapeutic research in pancreatic cancer. And his work focuses on pancreatic cancer biology and in particular to treatment personalization with particular emphasis on transcriptomic and AI-assisted tools. So welcome again, Nelson, and thank you for participation and giving us the seminar.
Thank you, Ingrid. I'm very happy to be there, sharing with you and with the people that is connected today some of the data we are generating in Marseille. So we are in the south of France. I'm also co-lead of the translational research and innovative therapies in the Cancer Center of Marseille. And this is why I'm working on pancreatic cancer, is because we are trying to identify the way to predict what will happen with the patients when they are diagnosed, in the way to personalize the treatment and to use between the different treatment we can have the more efficient. So we know right now from many years that only one treatment for all the patients is not more real, is impossible. The pancreatic cancer is so heterogeneous that we need many times combination of treatments to have good results. Why? Because if we don't know which is the good treatment to use, we will use a mix of different drugs to tackle the tumor with from different ways. For the reason that one of the gold standard treatments, one of the main treatments used today is FOLFIRINOX that contain 3 different drugs, Abraxane, irinotecan, oxaliplatin, and 5-FU. That this treatment with these 3 drugs is efficient only for 35% of the patients, not for all. And the alternative to this treatment is gemcitabine that can be associated or not with Abraxane, that is much less toxic, in particular the gemcitabine compared to FOLFIRINOX. The problem when we use combo is that we will add all the toxicities of each one of the drugs we are using, and the treatment became very difficult to sustain until the end of all the cycles, and many times the treatment should be stopped with the consequences, the strong consequences for the patients. So as I said, a visual manner to identify the differences in the tumors or the heterogeneity is to see anatomological slices, as we see here, from poor differentiated aggressive tumor to the well-differentiated tumor that is completely different from a visual point of view. That means that the tumors are really not the same. And for a biologist like me, that means that the biology should follow this heterogeneity, and the molecules that are in those tumors, that are building those tumors, should be different. So our idea was to identify markers that can identify not only the differentiation grade of the tumors, but also to which therapy they will respond. Something important that is emerging now are the targeted therapies that were BRCA, so the olaparib inhibitors like PARP inhibitors that we have already in clinics today, for the patients that have a particular mutation in BRCA genes, the MSI and the fusions that are also MSI are the patients that will respond pretty well to immunotherapy, and the fusions that will concern enhancers and some oncogenes that can be blocked by, for example, tyrosine kinase inhibitors. Those therapies are working very well with very good results, but only concern 5% of the patient. And maybe the most important result we have in the last 30 years are the RAS-targeted therapies. We know that in the last ASCO meeting, there were a standing ovation for the daraxonrasib and RASolute clinical trial that show multiplying by 2 the survival of patients in the last line of chemotherapy with daraxonrasib, that is an inhibitor specifically designed to block the activity of the oncogene that is mutated in most of the pancreatic cancer, that is RAS. is mutated in more than 90% of the tumor. So this is a case, not 5%, it's more than 90% of the patients that will be able to respond to these therapies. But even on those RAS inhibitors, for those RAS inhibitors, the patients will develop resistance and will have a relapse. Because even if we multiply by 2 the survival, we go from 6 to more than 13 months. 13 months is still too short because the patient relapse, and we know to understand how to treat those patients that relapse. So which was our strategy in Marseille? Was to build a huge biobank having models. For a biologist, a model is something where we can recreate the reality in a plate, in a dish plate, in vitro, or in animal models in an animal house. And this allows us to control many variables and to, for example, challenge the models with chemotherapy, seeing if the tumor responds or not, and then associating to those tumors the markers that can identify this capacity of the tumor to respond or not. We have a huge biobank, one of the highest or the largest in Europe, containing primary cell cultures, organoids at 3-dimensional models, and the xenografts that are grafted in mice, in nude mice. We have a lot of different tumors, and all come directly from patients, from resectable and from metastatic patients from the primary site and from the metastases. What we do so? We challenge the models. You can see here the example that we have for gemcitabine in primary cell cultures. This is the drug concentration, increase in drug concentration, and the percentage of viability of the cells 72 hours after the challenge with the chemotherapy. And we can observe resistant curves, sensitive curves, and associate those curves and those cells to markers, in particular transcriptomic markers. Very similar, we can do the same thing with PDACs. Then here we do not inject different concentration, but we inject a precise concentration of the drug, and we follow the growth of the tumor during time. And you can see here in the red part, a resistant patient where the treated model in green grow in the same way that the control, not treated, the violet. And you have here a sensitive where the treatment have a strong impact, stop completely the growth. And here, for example, on the left, you have a model that produces a relapse that is very similar to what happened in the clinics. You have a stop of the growth of the tumor, and some days after, about 60 days, the tumor grow again, resisting with resistance to the treatment. With this information, what we do is we build an anti-cancer drug sensitivity score for each one of the drugs, knowing which is the model that is more resistant and the model that is more sensitive. And then we associate this anti-drug sensitivity score with RNA-seq. Why RNA-seq? Because it's a more transferable to the clinics omics we have today. Two are the main, genomics and transcriptomics, because sequencing is right now very used in the clinics, much more than proteomics or other omics that are much more expensive and not so accessible for the hospitals. So we transfer that for the RNA-seq, and also we associate because as I said we are using models. The models do not represent completely the reality, and in particular the models we are using do not represent the reality because they do not have a real stroma that represent in many of the cases more than a half of a tumor. You know that epithelial neoplastic cells are many times like small islands in a huge stroma or desmoplastic reaction that contain fibers, fibroblasts, infiltrate, and many other cells that are not neoplastic cells. And for this reason, we use by artificial intelligence tumors, real tumors from patients, and we include a training system, an algorithm that train the signatures we have by RNA-seq from the models with what happened really with the stroma and the immune infiltrate in the real patients. Then with those analyses, we derivate what we name signatures that are able, is a combo of transcripts with levels of expression that informate us about the sensitivity or the resistance of a patient. Why doing that? Because we know we need to go ahead very rapidly. A patient should be treated when it's diagnosed in 1 or 2 weeks. To grow a model, we need many months. For organoids, we need 2 months. For primary cell cultures, we need more than 6 months. For PDX, also between 6 months and 1 year. And we do not have time to have the models in vitro to test in the models the chemotherapy and coming back to the patient. 2 months is too much. We need to have a response in 1 or 2 weeks. For the reason what we are doing, we derive the signatures we have to be able to perform in paraffin-embedded tissues that are used in the clinics normally to have a diagnosis. And in only 2 weeks, we are able to run the algorithm and to obtain the result and the prediction. So then I will show you how we validate that in the clinics in a retrospective way. That means that we will use, in the first example I will show, for resected patients that represent 15% of the normal population, we obtain RNA from about 500 patients. They were randomized, the cohort was randomized in the patients that received FOLFIRINOX, the patients that received gemcitabine. All the patients were then resected, and we obtained the biopsies from the resected tumors, and we prepared the RNA, and we use the signature to predict what will happen. As you can see here, this is the example for gemcitabine. In green, you have the patients predicted sensitive to gem, and in red, the patients that are predicted resistant to gem, the disease-free survival, and the overall survival. As you can see, the patients predicted sensitive treated with gem survive longer than the others. And when we compare what happened with the patients predicted sensitive or resistant to gem but treated with FOLFIRINOX, we observe that there is no difference, but more, that the difference that the patients treated for FOLFIRINOX, the more toxic treatment, goes as well as performing the patients that are treated with gem that is less toxic. This is the first important result because in this case we can avoid the toxicity of FOLFIRINOX in the patients that are detected sensitive to gem. So then we go ahead also with the drugs that combined form the combo for FOLFIRINOX, irinotecan for 5-FU and oxaliplatin, with very similar results. You can see here in brown the patients that are predicted sensitive and treated with FOLFIRINOX, sensitive for 5-FU, irinotecan or oxaliplatin by treating with the combo. So here you have the prediction for one drug, but the response in the patient also overall survival for the combo. This is important to keep in mind because now we can say, are those signatures for each one of the drugs capturing really specifically the response for one drug? The answer is yes, and we can see that here, you have here the patients that are sensitive to 0 from the 3, to 1 of the drugs from the 3, 2 and the 3 drugs from FOLFIRINOX. And you see an increase in the disease-free survival and in the overall survival for the patients that are more sensitive to more of the drugs. Then we binarize this signature, considering that the patients that are sensitive to 0 or to 1 are sensitive to the combo, and that are sensitive to 2 or 3 the 0 or 1 are resistant, and 2 or 3 are sensitive. Then, very probably the most important result I can show today, this is the survival of resected patients that we obtain if they are treated in the way that the signatures are predicted, in agreement with the signatures, and here the patients that are treated in the opposite way. One important curve is the violet, that are patients that are sensitive to FOLFIRINOX but treated with gem, and the opposite, sensitive to gem but treated with FOLFIRINOX. So those patients that represent about a quarter should, if they are treated in the correct way, they will reach the curves that are in green in the survival curve. And for the future, those in red are the patients that are resistant to all, that resist FOLFIRINOX and gemcitabine. And what we test in the last weeks were if they are also resistant, the models that are predicted like this are also resistant to daraxonrasib, that is a very, very promising drug, and they resist also. That means that they are resistant to all the drugs we can have, even the newest. That means that those patients, that represent a quarter of the patients, are really a particular kind of tumor that will resist all the treatment we can have. You will see how to go ahead with this. Then, of course, we try to adapt the signatures to the locally advanced tumors that represent much more than the resectable, 30%, and for the 50% of the patients that have metastases. Something that happens very frequently in the hospital is that if the patient is metastatic and the metastasis is accessible, the endoscopist will take the biopsy from the metastasis and not from the primary site. And we should adapt the signatures to be able to perform also in metastatic sites like in the liver. So you will see the results we obtained were very similar. We use a cohort of 100 patients. Here, where all the patients were metastatic, all were treated with gemcitabine. We had 57 patients from primary tumors and 28 from metastases and 16 from we have from the same patient, primary and the metastases. The results were very similar, were already published. I will not go into this part because I would like to show you how we are treating now with what we are doing with the patients that are multi-resistant. So the results were very similar. We obtained very good results in the primary tumor, also in metastatic samples in metastatic patients with gemcitabine and also with FOLFIRINOX that were tested in the COMPASS clinical trial cohort from 94 patients. So as I said you now, our problem or our future is to validate in a prospective way. 3 clinical trials are being done actually in France, the PAXIGN, GEMSIGN, and NeoPredict clinical trials. For PAXIGN for metastatic patients that are fit for the treatment with FOLFIRINOX, where the 5 signatures are being tested. GEMSIGN, that is ongoing in the Institut Paoli-Calmettes here in Marseille, for patients that are metastatic and that are not fit for FOLFIRINOX, so are only treated with gemcitabine, and we are seeing if the patients that are treated with gem, predictive sensitive to gem, are performing better than the patients that are predictive resistant. And the last one, the most important clinical trial, is NeoPredict, that is a national clinical trial, will open in September of this year. So we will try to have a window of observation in patients that are neoadjuvant, so that will be treated and then resected. This is a very important cohort of patients because those patients, we are really a possibility to have a good impact, a strong impact in the survival, because if the patient is detected sensitive and resectable, because we treat the patient to resect it, if the patient do not respond, we cannot resect the tumor. Right now, we have 60% of the patients without predicting that are resected. We treat, and 60% of them respond and can be resected. But the 40 other patient is not resectable because they resist. If we know what will happen, we can give to each patient the correct drug, and we will have more than 60% of the patients that will be resected, with a huge impact in the survival and the quality of life of the patient during this disease. But now for the future, what we are doing right now. We are working with multi-resistant patients. We are trying to understand what happened with them and to try to identify new drugs. For the reason, the first thing was to identify models, organoids, PDACs, and primary cell cultures that are multi-resistant, and we treat them with daraxonrasib to see if daraxonrasib could be the solution for those patients. And the answer is no. Most of them also resist very, very strongly, very, very well to daraxonrasib in the very beginning. So how to deal with those tumors that are so resistant? The first thing is to characterize them. What we did was to identify markers that can be markers for prognosis, to identify how the prognosis of the tumor will be, but also markers that can be target, that can be actors of the tumor evolution that can be blocked with drugs or with antibodies, with ADCs or with bispecific or with CAR T cells to block those cells that are more aggressive. In this way, to characterize the characteristics of those cells, we use 2 cohorts, the resectable and metastatic cohort, having more than 500 patients. We have here the graph representing the patients that are detected resistant to all the drugs, in red here. You see the multi-resistant versus sensitive in the metastatic, the multi-resistant versus sensitive in the resectable, and you have here a lot of patients that will resist. And we obtain in those patients 144 genes that are upregulated and 73 that are downregulated. In the 144 of these targets, we named the signature PANC profiler, are maybe good targets for the future that should be blocked to block the evolution of the tumors. But how to go ahead? What we did was to try to understand which are the molecular pathways that are enriched in the PANC profiler signatures, and we observed that transdifferentiation, epithelial to mesenchymal differentiation, is very strongly represented in those tumors. The extracellular matrix remodeling, mechanotransduction, stress survival are cells that respond very, very well to stress. Metabolic adaptation that is associated to plasticity and to the ability of the cells to adapt to a new situation like the cells will face after the treatment, because the treatment will have an impact in the tumor, and the cells can adapt to this treatment or to this new equilibria and survive. Motility and invasion that are characteristic of aggressiveness, and maybe the most important thing is that persistence-like survival circuits. That means that the cell will stop growing, stop dividing, go into quiescence, and doing like spore can do in bacteria, stopping the metabolism, waiting until the stop of the chemotherapy and coming back again, giving the relapse. But the thing is that what we are observing is those cells that relapse are trained to be more rapidly able to respond to the next line of treatment, being what we name resistant. What we did then, so we said, okay, that means that maybe we have 27% of the patients that will have a lot of cells that are multi-resistant, but are those cells present also in tumors that are sensitive? Because we are doing bulk sequencing, a global sequencing, and maybe some of the cells that are there are multi-resistant. The answer is, well, this is the hypothesis. You have here the hypothesis. So the red ones are the multi-resistance. That means that when you treat, all the cells become resistant because the cells that are green and are sensitive disappear, and you have a relapse. This is what we name intratumoral heterogeneity. To resolve this problem and to identify the multi-resistant cell not only in bulk but also at level of single cell, we need to go into the clinics to have a very good single cell reference. But because we know that single cell analysis cannot be done in patients because it's very expensive, we need a lot of tissue and very high quality tissue that we do not have in the clinics. So to have a good single cell reference, we need a patient with a strong, big quantity of tissue, in very well quality is very difficult. So we say we will do that in models. We will use our models to establish single cell reference. To have this good reference, then we are able to do the convolution and to identify the proportion of cells that are resistant or sensitive in a patient. The convolution is like if we listen the different instruments in an orchestra, the violin and the different instruments, we can identify them when they play all together. This is the same thing. Having a good single cell reference is to understanding which is the transcriptome of each one of the cells, and then knowing that to try to understand what happens when you have a bulk general sequencing and identifying the different proportions. So we go ahead with our models. We test in PDX, in organoids, and in primary cell cultures, and we observe that the more heterogeneous model we have that capture the best heterogeneity are primary cell cultures. And we identify 6 different groups of cells, the classical, the squamous, the epithelioid, the mesenchymal, and 2 intermediate, very plastic, that are the intermediate 1 and intermediate 2. Here they are. What happens if now we have the cells that are the more different models and we do an analysis in single cell in the primary cell cultures, the things become much more complex because we see that the cluster G1, 2, and 3, or 4, or 6 are also composed by different programs. A program is a group of genes that are modulated together, that move together in the expression, that are associated. We identify them by co-expression and co-regulation, but also by interactome. That means that the proteins that are produced by those targets, those transcripts, also interact between them, making sense, giving sense to these different programs that compose each one of the clusters, each one of the groups that I mentioned before. So then which is the strategy? We know that we have different groups of cells, that those cells are decomposed in different programs. And what we are trying to do now is to identify gene signatures, to characterize gene signatures that are associated to pathways and to functional annotations that have a role in the tumor evolution, then to compare those signatures in single cell with bulk phenotypes, that bulk transcriptomics, to transfer them to the clinics, and of course associate to clinical features, to the outcome of the patients or to the sensitivity of the patient to the drugs. Finally, to translate that to the patients, so to collapse the complexity we can observe here in a few robust meta-programs that can identify the multi-resistant cells, to validate them in multiple international independent cohorts from patients resected or not, to link, of course, to the outcome and to the response to the therapy. And finally, if we are able, we will identify new actionable molecules that can be new targets, developing new drugs and new systems to better treat the patients, even the patients that will be sensitive to the drugs, to identify the multi-resistant multi-resistant cells. And in the last part of my presentation, I will show some of the results we obtained in the evolution of the tumor, because we know that many tumors are resistant in the very beginning, but some of them are sensitive in the beginning, and even in most of the cases, they will have a relapse. How those tumors evolved after the treatment? So here we have the 6 different groups I mentioned before. Please pay attention to the pink one. That is a subgroup of cells that we identify by single cells, establishing a very, very robust system of single cell analysis that is basal-like. We can see here, this is a score of basal and classical, classic being the more better prognostic tumors, classical the better prognostic tumors, basal the more aggressive tumors. Here you have the multi-resistant score. You see again 3 of the groups of the cluster of cells that are very multi-resistant, and this is epithelial mesenchymal transdifferentiation, where you still have 2 different groups that are very resistant. So in summary, we have a G1 group that is classical, low AMT and low or intermediate resistance, the G2, 3, 4, and 5 that are intermediate, and the G6 that is basal-like, EMT high, and multi-resistant. This is the worst. And this signature will represent the signature that is the worst cells we can have in a tumor. What happened now when we have a model, a PDO, and we compare a PDO that comes from a classical or from a basal-like patients. This is the basal-like is a bad prognosis, classical, good prognosis. You can see that the pink group, the pink subclone of cells, is increase in the basal-like. What happened now if I have a classical, but I treat it with chemotherapy? I observe also an increase a few weeks after the treatment. That means that the treatment is increasing the pink, the multi-resistant subclone. And then a basal-like. Are the basal-like able to still increase the pink that is already have in the very beginning? The answer is yes. Even in the more aggressive tumors, the treatment increase the proportion of cells that are multi-resistant. Here is a picture that shows the distribution in this cohort of patients. It's a 40 patient cohort, where we can see that the pink subclone of cells is present in all the patients. Even here we have the more aggressive tumors, the worst prognosis tumors, where the pink subclone is very important, and even in the blue ones, where the classical subpopulation is very, very high, they also have a subgroup in the tumor that is multi-resistant. What happened in the different stage of the tumor? You can observe here resectable, borderline, metastatic from the primary tumor, and metastatic from the liver, when we also see an increase of the multi-resistant cells and a decrease of the basal-like or more sensitive cells, a decrease during the tumor stage, during the time. And finally, the treatment in the patients, I show you what happened in the organoids, but here we can observe also in the patients that are patients naive from treatment. And here we have the resection of the patients after the treatment, where we can observe that the proportion of the pink cells increase, the aggressive cells increase after the treatment. But all those things were done in single cell. And as I said you, we cannot transfer to the clinic. We need to do bulk sequencing to identify the different population of the cells. What we did, we used the convolution in the PRODIGE 24 cohort with 350 patients that were resected, that were treated or not with gemcitabine and with FOLFIRINOX. And what we observed is that when we analyze those cohorts, we observe if the proportion of a group of patients here in orange is very high for the pink, like here in the second, in the green one, and here in the pink one, the pink subclone is very highly represented. Here we are working with the convolution, identifying the bulk sequencing, the signature that identify the pink aggressive cluster. So, and you can see that the ones that are highly represented, the multi-resistant cells survive less than the ones that have highly represented the blue one, also the light blue, that are the classical cells, much more sensitive. That means that we can predict the survival of the patient by the convolution, identifying the different subpopulation of the cells in a tumor. So that means that this is a proof of concept that we are able also to develop signatures that are able to identify the different subpopulations. What we are trying to do now is to identify the targets that can tackle the multi-resistant clones. So what we observe again is that there are axes that are very well represented. Is the MET AXL axis in the multi-resistant clones, so AXL and the pathways that are guided by MET signaling pathways are important and putative targets for the future. The ECM remodeling and mechanotransduction and stiffness adaptation are also many molecules that are represented in the targets we identify. So the next step is to block in vitro those targets by shRNA modulation, so knockdown of the genes that could be targets, Cas9 modulation, and to see if they are many of the characteristics of aggressiveness of the cells are decreased when we block those targets, and then to develop new drugs and new treatments to treat the patients that have multi-resistant cells. So I will stop there. As a take message home, we can say that the transcriptome can inform and can help us to personalize treatments. That pancreas view, the signature we already obtained, was validated in retrospective way and will be tested in prospective way to personalize the treatment for patients. That gemcitabine, when the patients are detected sensitive to gemcitabine, can be treated with this treatment having much less toxicity than FOLFIRINOX, so avoiding the toxicity of a combo that is not necessary, and the integration of single-cell transcriptomics with the panc profiler signatures will reveal mechanisms and programs and sensitivities that can identify subpopulations and refine the understanding of PDAC evolution and enable to identify new targets and new treatments. I would like to thank all the patients that contribute with the consent to do science with their tumors for the analysis we are doing, the clinical groups that are working with us, the Paoli-Calmettes Institut and the different APHM is the hospital from Marseille. Rémi Nicole, because he worked with us in the very beginning with the signatures, Gustave Roussy, Institut Curie, Paul Bruce, Beauchamp, and all the other people that are working with us, the clinicians, and our team in Marseille, the pancreatic cancer team, that are working with me every day trying to have a solution for this terrible cancer. Thank you for your attention.